Hello, my name is Gladys Ng. I'm a reconstructive urologist here at the David Geffen School of Medicine at UCLA. And today we're going to talk about genital gender affirming surgery, specifically vaginoplasties, transition from male to female, some considerations before and after surgery, as well as the surgery itself. So some of the items we're going to talk about today are what is, going back to the basics, what is genital gender affirming vaginoplasty, criteria for vaginoplasty, as well as preparing for a vaginoplasty, the surgical overview, and some relative anatomy and terminology, and some post-operative care. So going back to the basics, what is gender affirming vaginoplasty? It is a trans-feminizing male to female procedure using the natal male genitalia to create a functional and or aesthetic vagina. There's kind of two options, a vaginoplasty with a canal for penetrative intercourse, and then a vaginoplasty without a canal or vulvoplasty for the appearance. We'll focus a little bit more about the full vaginoplasty with the canal in today's talk. What are the goals of a vaginoplasty? It's basically to attain an appearance of indistinguishable from other women, and although there is no real uniformity of appearance in the vagina or vulva in cis women, it's also to create functional goals, retaining erotic sensation, as well as a canal if desired for penetrative intercourse. And the benefits are that after surgery you can have secondary benefits are decreased hormone requirements because the testicles are removed, leading to no production of testosterone, so you don't need blockers anymore after surgery. And it just helps with better aligning your gender identity with your body to make you feel more comfortable, and you can feel a lot of patients feel very much comfortable after this procedure for that reason. Okay. So some of the criteria for doing surgery kind of follows from the World Professional Association for Transgender Health. This is an international organization or association for health professionals. It was first founded in the United Kingdom under the Harry Benjamin Foundation. He was one of the first physicians and endocrinologists that treated patients with gender dysphoria, and soon this organization grew internationally into a big association where they committed to ethical as well as safe treatment, healthcare treatment for transgender patients. So some of the criteria specifically for genital surgery is that there's documentation of gender dysphoria, and keep in mind these criteria are not to serve as barriers or diagnostic tools in any way. It's just that the surgery itself is it's irreversible. So another criteria is to have capacity to make informed consent for treatment. You have to be of a legal adult age, and then some kind of real life experience with 12 continuous months of hormone therapy, as well as 12 continuous months of living in the gender role, and then some supportive letters of assessment from some of your healthcare professionals that have been involved in your care, really to support your progress and the hormones and how the transition has been, and then also making sure that there's no other major medical conditions that would lead to bad outcomes from surgery itself. So making a decision for vaginoplasty, genital surgery can be complex, and really before coming to the surgeon, you want to essentially ask yourself, as you all know, is this surgery essential to you feeling as a whole and integrated person? And talking to a surgeon in the consultation, as I do with my patients, won't help you make that decision, but certainly we can talk about the procedure and the surgery itself, the risk, what it involves, the procedure, how much time it involves, the whole process itself, the risk and benefits, and possible complications to any kind of surgery that kind of help you make that decision as well. Okay, so getting to know your surgeon is very important, and that's why in meeting patients, I like to get to know them on a little more personal basis, understand their medical and social conditions as well, and helping them make this transition, and also talking about them, what their concerns about the functional and also aesthetic concerns about the whole reconstructive surgery in and of itself. So this is all very important, and all very important prior to the date of surgery, to meet your surgeon and have these conversations. I also like to discuss, because infertility is a result of the surgery itself, discuss reproductive options at that time. Some patients may have already have their own children, but for those that have not, there are options out there, such as banking sperm, or if further technologies are needed, I have other providers that are specialists in fertility that I'm happy to send my patients to, that can discuss options of it. If you do choose to do any kind of sperm banking, sometimes the requirements for the hormones may be less, or may need to be decreased in order for production, but this is all something we can discuss during the consultation itself. The other thing to consider in choosing a vaginoplasty is the timing of things. It is about a 4 to 5 hour surgery on average. We do need some preoperative workup before, and we'll discuss it later on in the presentation. And usually in the hospital for like 5 to 7 days, and recovery takes about 8 weeks. And during this time period, you're in the hospital, we take care of everything. We kind of show you how to take care of yourself afterwards. But when you go home, there's a little bit of a dilation schedule. We'll talk about that in a little bit. But you also want to have the support of family and your partner as well, in helping you take care of things. And we'll also talk about a list of items to have on hand prior to coming into the hospital before surgery, once you decide upon the surgery itself. So the preparation for surgery, and I mentioned these specific items because it takes a little bit of time to set in. It's not something that you kind of choose the day before, the night before surgery. And so it's good to speak about it, because typically we ask patients to stop estrogenizing hormones about 6 weeks prior to surgery. And this is for the reason of decreasing the risk of deep venous thrombosis, or blood clots forming in your veins that could be potentially fatal if they progress to the lungs. And so we want to decrease the risk of all of that. So we have the patient stop hormones at that time, the estrogenizing hormones at that time, 6 weeks prior to surgery itself, once the date has been obtained. And it can be started up about 2 weeks after surgery, once you're a little bit more mobile. But you also have to keep in mind that there could be because of the hormone changes, there could also be mood swings that can be associated with being off these hormones. If you are a smoker, we prefer that you stop smoking altogether, but definitely 8 weeks before surgery. And the reason is that this can also increase your risk for the blood clots that I just mentioned, but also when we're using the skin tissue to create the canal, the blood supply is very important, and smoking is something that can affect the health or the outcome of the vaginal canal in terms of using the skin to reconstruct it. And then the body mass index of 30, meaning that it typically means obese if you're 30 and above. And it's just more tissue to heal, more chances for infection, and it's also in the groin area, or in the area in between the legs where the surgery is being performed. It can also affect the ability to bring the tissues together for the more cosmetic part of things. But if there's too much tissue, meaning subcutaneous tissue or fatty tissue, then it may be a little bit harder to do reconstruction. But that's something that can be assessed during the consultation itself with the surgeon. Sometimes it depends on where the fat is also distributed. But typically 30 and below is what we'd like to go by in terms of criteria. And then it's good to understand that after the surgery, there's going to be a lifelong commitment to dilation of the vaginal canal, because we're using skin tissue or bits of skin tissue to create that cavity. But to put, initially after surgery it's going to be a little more intense. It's almost, almost 3 times, and we'll talk a little bit more about detail about that in a little bit. But, to put in perspective, in about a year's time, it's about 2 or 3 times a week. And if you're having penetrative intercourse, then that can switch in for a dilation schedule. So it's not that cumbersome, but it is something that you'd have to continue on for the rest of your life to keep the vaginal canal open. And then hair removal, since we do use scrotal versus penile skin, or somewhere around there, or a combination of both to create the canal, hair removal either by laser or electrolysis takes some time to be done prior to the date of surgery. We usually give patients on average about 4 to 6 months. So that's something to keep in mind in planning. So this is just a list of items that I ask patients to purchase prior to coming in for their surgery, so that after your surgery, when you're discharged home, you're not on a scavenger hunt to find all these items with a fresh room and just fresh wound and feeling kind of under the effects of just having a major surgery performed. So usually I like patients to have on hand some water-based lubrication. And initially, when you're dilating 3 times a day, it's good to have as much lubrication as you need to kind of to ease the dilator in and get a sense of things. As you get more proficient, you may not need to use that much lube, but just to have on hand, it's better to have more than not enough initially. Also, some disposable underpads, because it could get messy as you dilate, and then also douche to clean the canal. Dilators, we ask that the patients purchase them before the surgery itself. I will show you a picture of them. There's various sizes and various types, but we have particular ones that we suggest. Also a douche as well, and that helps to clean the cavity. Some paper towels, a good stock of paper towels, some strong absorbent kind, some bacitracin antibiotic ointment to put on the suture area, some feminine pads, and the best is the ones that are cotton lined, just because the sutures are still fresh, and it'd be just more comfortable. And then also some throwaway large loose underpants, because it could get soiled during this time period as you heal. And then a handheld mirror, because this will help you kind of understand your anatomy as you get used to your anatomy. We'll teach you all of this, but this takes some time to kind of settle in after surgery when you're on your own after discharge from the hospital. So kind of what are the main components of a vaginoplasty? Now we're going to talk about the surgery itself. There's really 6 main components. One is the penectomy, or what that means is removal of the penile shaft, the erectile bodies. The orchiectomy, which we do on both sides, which is removal of both testicles. This is where the testosterone is produced, and this is where after it's removed, there's no need for testosterone blocking hormones because of that. The vaginoplasty portion, which we're just talking about, creating the vaginal canal using either skin or scrotal skin. The clitoroplasty, which is using the portion of the head of the penis as well as the nerves to the head of the penis to create the clitoris. I'll show you a picture of all this. It's kind of hard to imagine. And then the urethroplasty portion, which is where we shorten the urethra and reposition it, so that you'd have to sit down and urinate from here on out after the surgery is performed, but it's shortened and also creates more of a pinkish appearance, more of a vulvar appearance that sits below the clitoris. And then finally the labia or the vulva, which is the outward external skin appearance of the vaginoplasty. And this is the creation of the lips of the vagina and the external appearance of the vagina, as I just mentioned. And that's using the skin. So the most standard way of creating a vaginal canal, just want to talk a little bit about creating the vaginal canal itself, is using the penile skin. The skin of the penis, we kind of invert it inwards like a skin graft, and that's why the whole, keeping healthy and no smoking is important, because it's basically a skin graft in the area that we create for the skin to take into. So the benefits is that the penile skin is relatively elastic, and it's hairless and less likely to contract on itself, and has really good, pretty good blood supply. The thing is, if it's small, or there's from being on estrogens, or if patients are circumcised, which is non-common, then there's just less skin to work with. There's also a combination of penile and scrotal skin, using the skin of the penis as much as you can, as well as using the underside of the scrotum, or a flap of a graft of the scrotum on the top side. We can use that to augment the canal itself. And basically the benefits is giving extra length and width to the vaginal canal. And then because you're still using the penile skin, there's less tightening of the entrance of the vagina. Disadvantages is that because we're using scrotal skin, then you'd have to use hair removal, and sometimes depending on how that flap is created with the scrotal skin, you may be a little bit risk of prolapse in terms of the canal itself. And these are all things that you want to discuss with your surgeon during consultation, as they look at your anatomy and look at the skin and see what there is to work with. So this picture is a picture of the female anatomy itself, a cis female, and the reason why I show it is just I want to show where relative structures are, and how they're similar to what we do in the reconstruction itself. So you can see that the clitoris sits here on the top, the urethra is a little bit below it, the vaginal canal is here in the cis female. In the reconstruction will be in our reconstruction, it will be a little bit lower here. We don't touch the anus part here. So the labia majora is here, and this is what we also kind of create. And the labia minora is the inner lips. And sometimes that may be more difficult to create depending on the amount of skin that is present. Okay. Now going to the male anatomy, there's no skin on this picture, a skeletonized picture. So typically what we use is this part of the head of the penis. This is what we use to create the clitoris, and the nerves that kind of course along here, and the rest of the shaft is removed. And then the urethra that sits right below this is also shortened, so the clitoris sits right here on the top, right at the base of the pubic bone, which is right here. And then the urethra is opened up to that area, so it gives you more of that pink vulvar appearance. And then this is the anus, where we don't touch again, but in between the space right here is where we create the vaginal canal. So giving you another perspective, a cross-section picture, you could see that this is removed. This is where the bladder and the prostate is, and this is the anal opening, or where it leads to the rectum and the bowels, and this is the space that we put we create for the vaginal canal. So in this picture, you can see this is the space right here where we create the vaginal canal. I'll give you a better close-up picture in the next slide. So you can see that the space that we create, this is the anal opening again, okay, which we don't touch, and then this is the space between the back of the bladder and the prostate and the top and front of the rectum, and this is the space that we create where we put the skin into to create the vaginal canal with either penile skin itself, if there's enough, or penile and scrotal skin itself to create this canal. I'll just put in a word about intestinal vaginoplasties as well. It's not common, and it's really not the first resort to go to, because it's a lot more to do and a lot more organ spaces to go through to use the bowel to bring it down. But in select cases, which you can discuss with your surgeon on your consultation, it may need to be used and if there's not enough skin at all. Okay, but typically, most common and standard is using the penile skin inversion technique. So then here is where the clitoris has been made, and this is the urethra opening, as I mentioned, and this picture also shows in the creation of this, in performing the vaginoplasties, there's always a concern, for complications as with any surgery, of the surrounding organs and tissues, and right next to the vaginal canal is the rectum itself, as well as the prostate and the bladder. It is also worth noting that the prostate is not removed in these vaginoplasties. So in older patients, if there's any concern for prostate cancer screening still needs to be done, especially in older patients. And if there's any urinary problems, the prostate could overgrow within the channel itself, causing urinary symptoms. So those are things to think about because the prostate is not removed. Okay. Oops. All right. So post-operative care, as I mentioned earlier, that you'd be in the hospital for 5 days, and it's really for that grafted tissue, the skin to take. And during those 5 days, we'll have packing in the canal, and it's just to allow the blood vessels to realign from that skin down to the cavity itself. And then on the 5th day, we will usually I will remove the vaginal packing itself and also teach the patient how to dilate and douche. This is just one example of a dilator set, and so we would go up sequentially, start with a certain size for 10 minutes, and then go up to another size for 15 minutes, and we'll start with that kind of moving sequentially up to whatever's comfortable for you. There are other dilators as well, but this is just one example of one. And then the catheter will also be removed on the 5th day, just because you'll be mobile, and you can we'll make sure that you can urinate with no difficulty. So during that time, we'll teach you how to dilate and also how to clean the canal as well with a douching device, bulb, and then once you go home from the hospital, we'll set up what your postoperative return to clinic schedule is at that time. So afterwards, your hospital stay is usually about 6 to 8 days, not weeks. Please excuse that error up there. And the recovery time, I'd say about 8 weeks. Just because for the first 8 weeks, I ask that patients do dilate 3 times a day. And that's why it may be difficult if you're, and you don't want to be running or going on the hustle and bustle of going to work and stuff like that. So it's better to just take that time off from surgery onwards to the 8 weeks afterwards, just to take that in consideration, because I do ask the patients to dilate 3 times a day just to maintain the canal. And it gets less intense after that. And then we usually see you after, and then we can kind of go down maybe 2 times a day. And this is an example of an enema douche, and it's made out of medical grade silicone because it's soft. You don't want anything that's hard and it can have sharp edges. So this is soft and pliable, but basically you fill this up with mild soapy water, and you just after you dilate, you insert the enema and clean the canal. And that's just to maintain the hygiene in the vaginal canal, the skin-lined vaginal canal. Okay. So as with any kind of major or any kind of genital surgery or major complex surgery, there are potential for complications, and some worse than others. But more common are the ones listed here. You can have wound changes to the area below, just because it's also a dependent area, meaning sometimes you can have collection of blood, like a hematoma, or sometimes the sutures may come undone. But everything heals up on its own. It just takes a matter of time and some wound care, and that's why we see you in the clinic, and we ask that you stay within the vicinity. And each surgery may be different, but I ask that my patients stay within the vicinity of Los Angeles for at least 4 weeks afterwards, so I can make sure that things are going well. And I usually see my patients within 1 to 2 weeks after surgery to make sure the dilation is going well and the wounds are healing well enough. But so wound changes can be common, and it's usually just wound care. Rarely need to get back to the operating room to fix those things. Longer term, if things are not what you expect, then revisions can be done, and they're usually not minor genital surgery. And initially after surgery, the urinary stream when the catheter comes out could kind of splay to a certain side or spray all over, but that's just because there's sutures in the urethra itself to kind of tack things up and keep things open. So that will usually self-resolve. That could be expected. Also, because of the dissection to create the clitoris, we dissect the nerves off the shaft of the penile shaft. Sometimes the nerves can be, in a sense, shocked from that dissection, and it could be numb for up to 18 months afterwards. So it may take some time, and also as initially when the tissues are a little more swollen, things you may not have sensation as you leave the hospital. Okay, so it just may take some time to get back to functioning again. And then there could be postoperative pain, which we'll manage with pain medications and pain control. And then also sometimes minor bleeding, and that's why I asked you, for you to purchase those cotton panty pads or panty liners, so that because some of the wounds are still healing, and depending on movement, some of the sutures could still be fresh, and the scabs can come off and cause a little bleeding, but a lot of it's just wound care, and we can certainly take care of that in the clinic when we see you back. And lastly, I wanted to show this picture because it kind of shows you the variability of the vaginas out there. And this is created by an artist in Brighton, United Kingdom, by the name of Jamie McCartney. He consented women and did a body casting of all their vaginas, and it just shows the variation in all the vaginas that are out there. So there isn't one standard look, and that's why also meeting with the surgeon to kind of speak about what you expect, what you would like. The external appearance and also with what your anatomy that you have is very important. But just to show, there isn't one standard conforming look to the vagina. And really the vagina is the canal. This is more the vulva itself. So lastly, genital surgery is likely life-changing surgery, but it's just one part in your transitioning care. And so I wanted to say that I do work with a whole team of physicians in the UCLA Gender Health Program, and not just physicians itself, there's all other supportive healthcare workers and members, and everybody's dedicated and fabulous in supporting care for transitioning for transgender patients. And so here are some of the services that our program offers. Other specialty surgical services, as well as just hormone therapy, and also primary care as well. And also case management and care coordination. And so I wanted to thank you very much for your attention today. And we look forward to helping you. We want you to feel the most comfortable being you. Thank you very much.